Welcome to the Teaching Value in Healthcare Learning Network. Join us to hear leaders in the field share practical and tangible advice about how to develop engaging curriculum and health system innovation to train a new generation of healthcare providers from diverse specialties and professions skilled to deliver high-value care. With national concerns about rising healthcare costs, as well as overuse, underuse, and misuse of medical care, Costs of Care and the ABIM Foundation creating the Learning Network as a space to share ideas, educational materials, and strategies in an open forum. Our goal is to discuss ways to get started, implement, and sustain feasible innovations in teaching value at your institutions. The Teaching Value in Healthcare Learning Network has three major components. The first being monthly webinars, which are approximately 15-minute sessions to hear on-the-ground and national leaders share successful innovations with a focus on how to adopt them to your institutions. Sessions are aired on the third Thursday of every month. We also have discussion groups that help facilitate getting advice on how to launch new innovations, and tools for educators and system leaders, which is a space to store materials needed to disseminate innovations across the country. I am Reshma Gupta, the director of the Learning Network, and I'll be moderating today's webinar. Today we will share an innovation in teaching value and discuss in-depth practical components of implementation, including how to obtain buy-in, resources needed, and advice for feasibility and sustainability. We are honored to have Dr. Jed Gonzalo join us today. Dr. Gonzalo is an assistant professor at Penn State University College of Medicine. He's a general internist, medical educator, and health services research with a principal research interest in collaboration and quality. Dr. Gonzalo serves as a core faculty member of the Internal Medicine Residency Program and is the Associate Dean for Health Systems Education in the College of Medicine, where he leads a design and implementation curriculum related to health system science across the medical education continuum. Today, we will be discussing a patient navigator program that he developed at Penn State. And what's really unique about today is going to be our focus on what it really means to scale and sustain the implementation of these innovations. So Dr. Gonzalo, I will let you take it away.
Thank you, Reshma, very much. I want to first start by thanking the Costs of Care and the ABIM for this opportunity to share our innovations here at the Penn State College of Medicine. I want to first start by highlighting two of the key needs for our program and why we built this program. The first is a need for students to add value to the clinical mission. Although data is a bit outdated, it would suggest that students are sometimes seen as a liability to the health system. If a student goes into the clinical setting, on average per day, it's probably 30 to 60 minutes by which the clinical preceptor's time is extended. And given the increasing regulatory requirements, there's a need for medical schools to think about how students can add value. The second is the need for students to develop competencies and skills in health system science. These concepts, such as interprofessional collaboration, policy, economics, informatics, population and public health, high-value care, health system improvement, systems thinking, we've all heard of and to a certain degree have existed in medical school curriculum over the past 5 or 10 years, but there's an increasing cohesion around this third pillar, which is being coined and termed health system science, which balances the basic and clinical sciences. And there's a new textbook out just last month. There's a number of articles that are using this phrasing and terminology over the past 2 to 3 years. These two needs, value and health system science, as you can see depicted in slide 1, kind of merge this new definition of value-added medical education, which we put forth here at Penn State, but builds upon the knowledge and the work of many others. And it's a definition that experiential roles for students in practice environments that have the potential to positively impact individual patient and population health outcomes, costs of care, or other processes within the healthcare system, while also enhancing student knowledge, attitudes, and skills in clinical or health system science. This definition is what drove our new curriculum. So in 2014, funded by the AMA's Accelerating Change in Education grants, we devised a new systems navigation curriculum, which includes 2 components. And the first is a health system science course that lasts 17 months, focused on all the health system science concepts. And the second is a new role for students to be embedded into healthcare systems to serve as patient navigators. The concept of patient navigation began in the 1980s and 1990s when a breast cancer surgeon, Dr. Harold Freeman, identified that many of his patients were coming to his clinic too far along in their care. And up sprang a new healthcare role, where these roles are linked with patients to provide education, psychological or emotional support, or help facilitate their access to care. We've modified this concept and molded it into a patient navigation model for all of our first-year medical students. And some medical schools use different phrasing and terminology, such as health coaching or system analyst, but they're very similar. The principles for our patient navigation program are mainly threefold. One, the experiences should be designed to add value. They should not be observing. We want them to really be doing within the healthcare system. Two, students should be embedded into an interprofessional care team within a community of practice. We want them to be in the healthcare system in which they are developing their skills and will practice as physicians. And students should interact with patients. Some of the logistics. This is a requirement for all of our first-year medical students. We are in our third year. We have 150 students at the Penn State College of Medicine. In the past 2 years, we've accommodated nearly 150 students. They go 2 to 3 half days per month, mainly in the afternoons, and they are going to a wide myriad of clinical sites. In total, we have a network of 41 different sites in 5 different health systems, and they are inpatient programs, primary care clinics, underserved free clinics, specialty clinics. So it doesn't have to be one type of patient or one clinic. Their mentors are extremely heterogeneous, and they include anybody on the interprofessional care team, and it does not have to be a physician. By and large, most of the supervisors are not physicians, although many are within the mentor cloud. So on slide 2, I've highlighted some of the implementation features of this, and this comes from a study that we collaborated with UCSF on that is now in academic medicine. The core center is current 6 steps for curricular development, which we employed in developing this curriculum. But we knew that devising something that is so novel and new that there were change features that we needed to factor in, and we superimposed Cotter's change model on these steps. So the first step is establishing that sense of urgency about health system science and value, which is a very big conceptual shift. The second is creating a guiding coalition, and I think this is very new for medical schools, that our collaborators here, our coalition includes chief quality officers, CNOs, CMOs, the C-suite, administrators, care managers, many of whom are kind of new to the educational realm because they haven't been called on before. Steps 3, 4, 5, and 6 I kind of view, and our program is very big, as the continuous quality improvement steps that's required to make this go. Since it's so new, there's so many novel things to it, it requires an everyday motion and process to make sure we're reaching our goals. And we've formed a team here. We can talk a bit about this more with a patient navigator coordinator, a program coordinator, and an office to really address the needs in real time. And the last 2 steps are 7 and 8 about celebrating success stories, which come about fairly quickly. You got to be creative on how you disseminate those. And the last is working this into your culture. And I think this is one that is very big and takes a lot of energy and time, and it's complex. And I think at the Penn State College of Medicine, our Vice Dean for Educational Affairs, Dr. Terry Wolpaw, is truly a visionary. And she has made this a priority that our medical education paradigm is centered around basic sciences, clinical sciences, humanities, and health system science. And students and faculty see that from day one. And I think that is a key leverage point for us in building such a program.
Well, thank you so much for that very clear description, and the paper that is in academic medicine is just wonderful to kind of describe this approach and really get your mind around, how large of a scope this is. As you said, over 40 clinics, mentorship for the students across interdisciplinary fields and are not just physicians. I love that you said that. And I think one thing that you just mentioned on that I'd love for you to talk about more is the culture piece. So for us to get a sense at your own institution, what was the culture before you kind of got into this work and then into this program? And then what do you feel was required within the culture, within the program, as well as the health system and the C-suite, as you mentioned, to allow this program to come to fruition? And then I think what's really unique is that fact that it's scaled and it's sustainable. What was needed for that in terms of the cultural support?
Yeah, so let me just first highlight that I think this is a key question, and we have not mastered this by any means. This is an everyday, I don't want to call it a battle, but it's an everyday work in process. So the culture here, I think, is like many cultures in medical schools, because I think that those who are educators in the education community have been brought up in a paradigm that they may or may not assume should be the paradigm of current day. So I think the cultural barriers on the med school side existed. Students come in with their idea of what a medical school should be doing, what their educational theory should be like, what the experiences should be like, and so do faculty, particularly those who have been around for a while. And that's because they're used to that system. So I think articulating a clear vision and going through these Cotter steps, particularly the early steps, is critical from a College of Medicine standpoint, but there's no doubt that you need high leverage coalition builders and key players such as the vice dean and the CEO and the dean to kind of make some of these things go. I will highlight that this is bringing the educational and clinical missions together. And Reshma, your article in 2015 highlights that with Dr. Arora. And for me, living this out as the educational community binds and blends with the clinical community, the culture from the health system was much more positive than I think I assumed going in, and I think many people might assume listening to such a program. You go to the CQO and the CMO and the chief operating officer, they understand that. When you read health affairs articles or education leaders, and they want systems-ready physicians and providers to enter the healthcare system who are ready to demonstrate these competencies, provide patient-centered care, and most importantly, perhaps, be change agents of the healthcare system. So when they hear concepts such as this, they want to collaborate because they see this potentially as a long-term victory for healthcare and our patients. And I think that was a very eye-opening period of time for me to learn from these health systems leaders that they actually want this. I think the bigger cultural divide, I think, was on the med school side.
Well, thank you for that response as well. And, I was kind of reading through that same paper about how do you merge these silos between education and health systems, where oftentimes the resources to create these programs is not readily available on the education side, and being able to find an avenue where it's a win-win for both sides, allows that leverage to be there so those resources are there. And I think one thing that you mentioned already is the scale and the scope, that because you're hitting all these providers, you're developing change agents, it really is going to lead to outcomes that the health system cares about and probably needs to report to in some way as well. So I think that's just great. The one thing that I think would be helpful to go over is a little more detail of what the medical students are actually doing when they're at these sites in the patient navigation program, to give the listeners a better understanding of how, in some ways, this will help the health system, in terms of their outcomes. And the second question is the resources that you think were most vital to create the scale for the program.
So to the first question, Reshma, we had the same questions, and that was one of the first questions I asked. And that's what spawned a research study that I'm citing on the first slide. It's in the American Journal of Medical Quality. It's entitled Adding Value to the Healthcare System, Identifying Systems Roles for Students. And we would go to these meetings with these clinical sites and site leadership, and the first question that I ended up asking them was, tell us about your patient populations. What is needed for them? And I think, one, they took a step back. Here's an educator coming to us not selling a product, but asking us about our needs. And I think that is a key piece to this. But out of those 45 minutes after that one question, inevitably in every meeting we talked for a very long time, came about the types of activities that students can do that could be value added. And we articulated those as a qualitative study in the American Journal of Medical Quality. And I think that's, if somebody wants the source, that's where it would come from. But the types of activities that they would do as they align with patient needs, it depends what setting they're in. But by and large, I think some are ubiquitous across sites. They're working with patients. They're communicating with them at the point of care within the clinic, sometimes through phone calls. We do home safety assessments and home visits to mainly identify their barriers to care that they are having as to why they may be falling through the cracks, why they may be super utilizers. I'm using it in quotes. I don't want to use it in a derogatory way. but they have gotten to the radar of the health system and to the students' work because of a reason. It wasn't because this is a great educationally valuable patient. It was they need help. The health system needs help with these patients, and some of them may be complex. So it needs to be tailored to what the patient may need. And it may be because they are non-adherent with their medications and they need a pill box. A student will walk into a home and there will be no wheelchair ramp, but they have a wheelchair and they have medications dispersed in 5 different parts of the home, and it's a remarkably unkempt home. So the students build a wheelchair ramp, get a medication pill box, and get some cleaning services into the house to clean up the house. And it sounds like semi-simple things, but from a student standpoint, which what they will tell us is, boy, I could not have gotten a better glimpse into a patient's life and to the barriers that they encounter, while also adding value to have them engage in that process.
I just think this is wonderful, because I think what you really highlight is to merge these silos, we need to have the conversations, knowing that the health system, the patient, and the students in the training programs all have the same goal as providing the best care for the patient's needs, and knowing what those needs are and opening those doors for conversation is what led to the program development. It wasn't prescribed before walking in the door. Right. And I also think it also allows for empowerment for the students, empowerment for the patients, and then reaching those health system goals. The second question I had was about the resources specifically that were needed for this, which I think, because the culture was already somewhat there to support the program, that might have been a bigger barrier, and especially to scale the program.
Yeah, I think this is a great question. And I will say that medical schools call me fairly frequently and say, hey, we read about this program and we learned about it through the AMA consortium. We are thinking about doing a pilot. And I will say that there's probably 12 or 14 schools I have on the list. Many of them just want to know about it and don't do it. Many of them do it and they're starting very small. They're starting with 4 or 6 students, 8 students, 15 students, and they're pulling it out of their clinical skills program in the first or second year, and they're just piloting to see how it goes. So I think what's implicit in that is that the scalability of this is remarkably difficult, and it requires to build a network of 41 sites and programs. I'm not tooting our own horn here, but this took a lot of time, a lot of sweating, and a lot of work and a lot of collaborations. So I wouldn't underestimate the amount of time and resources. Our team is 4 deep. We've got an admin assistant, a patient navigator coordinator who is a master's level gal. She's in her mid-20s and she's awesome. And we have a program coordinator who has been in education for 22 years, and myself. And we're the core team, and there's others around us, but we've carved out time by not us, by our bosses, to say this is a priority. So I think to do that in other places, again, I think that buy-in needs to be had from other areas. And the other one, the big one in the room, which I always get asking about this, is curricularly, where does this fit? You want to add something into the curriculum. Anytime you add something in, something needs to come out. And that is such a chock full basket of complexity in a medical school, because we have 100 to 120 contact hours over 17 months for health system science concepts, where students come back to small groups and reflect on their navigation. To do that on the curricular side, that's a huge leap. You need buy-in from your education team to make that happen, because something probably needs to come out.
Well, thank you so much. I feel like this has been one of my favorite discussions that I've had on the Learning Network, actually hitting on some big concepts. Just a wonderful program. I think it's daunting for someone starting brand new in developing something like this because of the scale, but I think the honesty about, it takes that buy-in. And I think the key things that came out of the discussion for me were the fact that asking the question, what is really value added for all the players at the table, getting all the players at the table to have the discussion about what's needed and of benefit to everybody, and how to logistically do that in terms of, the curricular time and what resources maybe from the health system are required. So thank you so much for being here today. And we will see all of you as our audience next month with another webinar. Thank you.
Thank you.